First, I would like to thank the organizing committee as well as the scientific committee to provide me with a topic that is close to my heart, that is psoriatic arthritis. And you know, this year, they even made it challenging for me by providing to talk about challenges in the treatment of PSA, specific attention to both the enthesitis as well as the axial involvement. So as usual, for those who know me, I like to go over cases, real cases from my clinic, and then talk about the unmet needs. We always have been talking about RA unmet need, but we do have in PSA and other diseases as well. I'm going to put the challenges in between with guidelines from the recent recommendations and some snaps about a very beautiful abstract that it will help you within your clinical implication. So let's start with the case. First of all, well, I was in my private clinic and a mom entered the clinic with her 19-year-old son. Yes, a mother with a 19-year-old son. And his story was the following. He developed a viral encephalitis, and unfortunately, he developed a brain injury and was mentally challenged. And I'm a pediatric because I cannot deal with pediatric patients. But when a patient, I learned from my pediatric colleague, when a parent comes with a child, you're dealing with two patients, and the most is the parents more than the patient, it's him or herself. So they informed me that there's a positive family history of psoriatic arthritis in his uncle, and he was having skin disease in the form of skin psoriasis, and then it progressed to psoriatic arthritis in the form of arthritis and axial involvement. He was given by one of my colleagues, TNF inhibitor, fantastic, and he was doing an amazing job. But the problem is his skin did not resolve. So they started him on ALT-17, which actually it helped his skin a lot. And this is not surprisingly. We know that the ALT-17, they work better in the skin and patient with predominant skin lesion. During the follow-up with the rheumatologist, they claim to have a plantar pain that is consistent with plantar fasciitis and was confirmed with Achilles tendonitis by the ultrasound. So that physician switched him to an IL-12/23 inhibitor. That's what the time when his mom presented with a patient telling me he's having a severe back pain that is inflammatory, and the MRI did confirm that there is a sacroiliitis. So the enthesitis is the same, but what's killing the patient and he's unable to bear is the inflammatory back pain. So the mom stated, when I was taking the history again and again, and I want to know which one is better, was it the TNF inhibitor, the ALT-17 inhibitor, the IL-12/23? She's saying, well, no, it was the ALT-17. It helped his back. So please return him back on that. So for the residual unmet need for a patient with psoriatic arthritis, with all the treatment options that we have right now almost 20 biological therapy and target synthetic DMARD for the treatment of PSA. I remember it wasn't long ago, about 10 years ago, that we only had one class, that is the TNF inhibitor. And as I stated earlier, we switched from one TNF to another, and just we said, this is as good as it gets. I can't do more than that. But despite all the options, still about a quarter of our patients, we don't achieve remission. The most complaint for our patient is the pain. And we're not sure, is it a somatic pain, is it an inflammatory pain, but they still complain of pain. And if you look at the patient reference, based on the US web-based survey, they do prefer oral treatment. And if you want to tell them, let's go with an injection, they will tell them, I will prefer the least injection. So let's look at the PSA guidelines and the recommendation. We do have the ASR. The ACR, which nobody looks at anymore because it's not domain predominant and it doesn't specify. What distinguishes the GRABA is the domain predominant. Now, I promise for some of you, I have a surprise. And the surprise is I'm going to present to you the actual EULAR recommendation that was presented in Milan 2023. I have the actual slides from Professor Laura Gazak from France herself, and she was very happy when I asked her to present it in the SSR. As well as I talked to many of the steering committee, Professor Joseph Smallman, Denise McGonigal, with regard to some point to clarify it for you. And it's under revision in the ANR, and you're going to have the chance to see it today. So what's distinguished the GRABA more than the ACR is the domain predominant. Now, indeed, I was asked to talk about both the enthesitis and the axial disease, but we're rheumatologists. I cannot pass the session without talking about the joint. So if you look for the recommendation with regard to the joint involvement, you could use anything. We have until now 6 different mechanisms of action with 2 target synthetic DMARD, and it depends for the peripheral arthritis on the patient complaint and what the physician decide. Now, this decision have been made on head-to-head trial, in which some of them toward placebo, but actually we only have 4 head-to-head trials. That is comparing the active comparator with the drug. We still have the bimekizumab to be approved in Saudi Arabia. It was approved for psoriatic arthritis by the EMA, but by the Saudi FDA, no. It is approved in skin psoriasis, and I have some of my patients on it for skin disease more than for the psoriatic arthritis started by the dermatology. So if you look for the guideline and the recommendation from the peripheral arthritis after failure of conventional DMARD, it states the biological DMARD to be started with no personal preference. I repeat, no personal preference and no order of preference from one to another. Please feel free, grab all your smart devices and take as much as picture you want. I'm giving you the permission for that. So what about when the biological DMARD is not appropriate? This is a strong statement, and please be careful how do you read it. It's with regard to the JAK inhibitor. So when a biological DMARD is not appropriate, and what does they mean by that? If there was a contraindication or the patient cannot tolerate the biological DMARD, that is injection, you could go ahead for a JAK inhibitor. Now be careful. And I spoke with Professor Smallman about this, and some of you may read it and they say, well, JAK, this means they're not in the first line. No, that wasn't the message. The biological DMARD was first because of the biosimilar. And the JAK inhibitor, as I stated earlier, it's just to teach you something is called risk stratification. And the other thing is take patient preference into your account. And of course, we know for the risk stratification, it includes patients above the age of 65 and other risk factors. So the challenge that I faced with such a patient, and you are facing, is the personalized treatment approach. And that's what's termed as precision medicine. Now, the University of Oxford, they are working on the precision medicine. And whenever we face any patient, we have a couple of blocks that we think about. And I would like to add to that is the predictors of response. In addition to comorbidity, the domain that you're all doing, the access to the patient preference, and the most importantly is the middle, the safety consideration. Now, as I said, there's an optimized trial that have been conducted by the University of Oxford in order to look at the blood work and decide for our PSA patient which medication is suitable for them. Until the results are released in 2025, we have to use our brain and we have to work hard with regard to that decision. Going from the GRABA website to differentiate between axial SPA and axial PSA, by the way, I will put for you a couple of pictures from the actual website, just for you to know it is already there and the difference is there. So first of all, it's more frequent in male and there's no gender difference. When you look at the X-ray, it's homogeneous syndesmophyte, and on the other side is asymmetrical unless slightly being symmetrical. Believe it or not, in axial SPA, the predominant symptom is inflammatory back pain. But in case of axial PSA, your patient actually may be asymptomatic. So you have the chance to look for axial PSA in the patient by doing an X-ray as well as MRI. Now, why is this important? Why do I have to spend time in looking whether it was an axial SPA versus an axial PSA? Simply because in axial disease, there are few biologic and target synthetic that have been approved. TNF inhibitor, IL-17, the JAK. What about the IL-12/23 and the IL-23? Well, there's only one trial in which the primary endpoint was the axial PSA. That is the maximized trial for the Cosentyx. And because the IL-12/23 was a failure study in ankylosing spondylitis, the FDA requested to have a special study in which the primary endpoint was the axial PSA. We know that there are a couple of studies for Skyrizi, as well as from Tremfya, the Keepsake, as well as the Discover, in which the post-hoc analysis, the patient did respond. But again, they're requiring a special study. So going to the statement and the recommendation, which is modified, patient with axial disease, IL-7 inhibitor, or the TNF inhibitor, and the JAK inhibitor, based on the ASAS-EULAR. I always like tables with traffic lights. It just gives me an example how to deal with my patient. And if you look at the reference, it's from 2022. I updated it just to add more medication, and we're looking forward for the new publication. So going back to our patient, 19-year-old, have an axial disease, have a peripheral arthritis, have an enthesitis. These are the domain that the patient have. And what actual treatment is he on right now is the IL-12/23. And as you could see, there is no recommendation and insufficient data for the axial involvement. So the proper way would be either the TNF inhibitor or the IL-17 in his case. And that's what his mom was requesting. So I asked her in an indirect way, as I stated earlier, which medication was the best. It was the IL-17 inhibitor. So what I did, I injected his SI joint with my colleague under fluoro. We injected his enthesitis, and we returned him back to the biological therapy, IL-17. So this is the first case and the first part of my presentation. Now this is the second case, which actually, believe it or not, I saw this patient just before the summertime last year. I walked through the hospital and I saw that physician who I know. And he was walking and putting his hands like this. And I looked at his skin and I noticed, well, I'm a rheumatologist, معلش, bear with me. اجتهدت وشخصته skin psoriasis, severe and extensive. So I said, should I talk to him? What should I tell him? كيف أوصل له الرسالة? Anyway, after a couple hours, I met him again. So I said, I really have to talk to him. So I went and I say, excuse me, how are you? Have you seen a dermatologist? He said, anyway, doctor, I came to you 8 years ago and you diagnosed me with psoriatic arthritis. Okay, so his story was the following. In 2008, he saw a GP because he was having a generalized aches and pain and was diagnosed with what? Surprise, surprise, fibromyalgia. 10 years, he's on NSAID, amitriptyline, and Lyrica just to relieve his fibromyalgia symptom with no benefit, unfortunately. In 2018, he started to develop a skin rash. And that's the time when he went and saw a dermatologist, Jazallah khair, قال له, go and see a dermatologist. So the first dermatologist, he told him, no active arthritis. It's again the fibromyalgia. That's when the time he came to me. And I examined him, assessed his joint clinically by the ultrasound. There was no sign of itis. I even examined his SI joint clinically, and we did an image, and there wasn't anything. But he did have classical enthesitis in the lower limb as well as at the costochondral junction. That is in the anterior chest. It's responding to NSAID. So I offered for him TNF inhibitor. And that was how long ago? 8 years ago. So what happened? I'll tell you in a second. So the second challenge that we have is pain in PSA patient or patient with psoriasis. Is it fibromyalgia or enthesitis? If we look at the prodrome, the skin starts first, then followed by enthesitis, and the last stage is synovitis with the damage. But sometimes it could be reversed, in which the enthesitis starts first. So why do we care? Because studies have been shown, especially a Dutch cohort, that the quality of life is reduced. Do you believe that? when they evaluated the quality of life for patient in psoriatic arthritis, it wasn't the joint that affected the quality of life of the patient. It was enthesitis followed by the inflammatory back pain. And that's what you could see in the spider graph, the more outside involvement for the enthesitis and the inflammatory back pain. As well as the MSK domain, like the previous patient I showed you within the satellite symposium, they may suddenly present with arthritis mutilans and joint ankylosis. And I would like to just refer to you for a project that has been done by medical students. They started when they were 4th year, and it was their graduation product, in which they evaluated the quality of life in PSA patients. And they did all the measures of quality of life that you could imagine, and I'm so proud of them. So please, go and read for your interest. The GRABA recommendation in 2023, they actually, with the Leahy Eder being the first author, they put a guideline. How would you evaluate enthesitis? There's a clinical, no wonder, and no doubt. And there's the points that we evaluate. And there's certain measure that is preferred in the peripheral arthritis, that is the MEIS, as well as in axial SPA, which is the SPARC and the lead enthesitis index. But it's always better, I repeat, it's always better to confirm it either with an ultrasound or an MRI in order not to confuse it between fibromyalgia. But the thing is, and this has been presented in the ACR almost since 2014, there's a discordance, I repeat, a discordance between the clinical and the imaging. So why is that? Denise McGonigal talked about this a lot, and he had lots of publication. The reason is, one of them, if you examined enthesitis on one occasion, it's going to be on one side. On the other clinic visit, it's going to be on the other side. And sometimes there's no concordance between the clinical and the physical, between the clinical and the radiographic exam. So what he proposed is to give steroid injection for such a patient and to see the response and follow the domain. So if you look for the EULAR recommendation, a patient with enthesitis, you could give a biological DBARD. There's no order of preference to be given. And JAK inhibitor may also be tried. Now, what did I say about my patient have? Predominant skin lesion, which is the IL-17, IL-23, IL-12, and 23 inhibitor. So what I did, this is my patient again. So I told him, hey, why you never showed up? فينك؟ 8 سنين. He said, دكتورة, when you discuss with me about the TNF inhibitor, and I work in a hospital, أنا بصراحة اتفاجأت وشردت. I like his word, شرد. So I say, okay, what are you afraid of? والله إنه ياخد وقت في العيادة when you discuss patient one-to-one, what's his patient preference. But sometimes you have to do it, especially when the patient is a healthcare provider. He say, I was worried about TB specifically, and I don't like injections frequently. The problem is he quit exercise because of the costochondral anterior chest pain and the lateral pain. He wasn't able to do any biceps curls or any weight lifting. So I discussed with him about the option, in which one of them is JAK inhibitor. أنا عارفة إنكم حتقولوا JAK inhibitors, why? He have a skin predominant, and I totally agree. But I was trying to go with him with a direction that he's pleased. So I asked my colleague from Derma to evaluate him, and once he said it's moderate to severe skin psoriasis, JAK inhibitor was out of the question, according to the EULAR recommendation. So I put for him the options, and I told him with regard to the side effect for TB signals is very low, as well as the other infection risk for the IL-12, 23, and the other medication is very low. So which one would you prefer? And that's what I did. I actually put these in front of him, and I show him which one is loading, which one is more frequent, and which one is less frequent. And he chose the following. This is his actual skin disease. And he's actually a good photographer, because after having the first dose, before even the second, I asked him to take a second picture. لو أنا ماني عارفة المريض أنا كنت قلت هذا فوتوشوب لأنه آخذ الزاوية الصح before and after. And he decided to go ahead with Skyrizi for a simple reason, it is less frequent. It's okay. I want him to be at least on treatment before he developed this full-blown disease. So With the following treatment, I'm just going to go ahead with a quick snap that helped with our clinical practice from the recent conferences. First of all, they were looking at the incidence of uveitis in axial patients. And if you could see, of course, the TNF inhibitor, they are the least, but the JAK inhibitor is following the next in the line for being safe and less incidence of uveitis. Now, Leahy Ada from Toronto, Canada, have been working and looking for predictors of response. For the biological DMARD patient, female were less likely, unfortunately, to respond to the biological DMARD. طب إيش نسوي? Okay, you have an option of JAK inhibitor because there wasn't much difference. Now, in the GRABA, there was a debate between Alexis and another physician. So I asked Alexis, for the debate of the use of biological therapy in PSO, who won? She says, Suzanne, I just let him win. And I would let the dermatology state that use of early biological therapy does decrease the incidence of PSA. And that's based even was confirmed within the ACR poster that aggressive treatment of moderate to severe PSO will lead to the resolve of the treatment and hopefully not to develop PSA. But be careful, please, when you read such a poster. It was based on electronic health record system, and they stated that the IL-17, no difference. When there is such a strong statement in favoring or disfavoring a single drug, the only way to confirm it by head-to-head trial or RCT trial, not by retro, not by health electronic system. So the good news is there's an ongoing trial to answer this and to confirm it. And I am pleased to announce that there was a paper with my colleague, Dr. Ibrahim Al-Hamoud, Dr. Bidawi, in which we are, with the dermatologist, we are trying to elaborate this more and encourage the early referral. So in summary, first of all, we have lots of advances for the PSA treatment. Again, the decision depends on the domain involved and the patient preference. It's important to differentiate between axial PSA versus axial SPA because some medication work in one versus the other. Enthesitis, indeed, it's an early and a key finding for PSA, and we have to treat it well and diagnose it well to improve the quality of life. And the final thought that I have for today, my vision 2030 for the rheumatology is to be one of the leads in the research and in the publication. I want to stand up one day in the ACR and the EULAR and looking as much as poster from my country and my registry. And at that time, I will say, this is my country, this is my flag. Thank you so much for your attention.